I wish it could.
Hello, people. Attention, attention. It's time to learn. All right. So, wrap up your conversations. Thanks. Okay, we're going to talk about ILD again. We talked about ILD before, like a month or two ago, and we're going to cover a little bit of what we covered then, because everyone benefits from hearing things multiple times, and because some people may not have been present for ILD 1. We're going to talk about imaging patterns. We're going to talk about different types of ILD. The last time we talked mostly about like how you get to a diagnosis of some kind of ILD, and we talked about IPF. Now we're going to talk about a bunch of other kinds of ILDs, things associated with exposures, associated with medications. We're going to talk about sarcoid, a few other little random ones. I'm going to throw some questions in to keep you paying attention. Okay, so last time we talked about how you might come to a diagnosis of ILD by working a patient up for dyspnea. Of course, a lot of the times you actually, like, the person comes to you already with an abnormal CAT scan, or you're taking care of them in the hospital. So there's all different ways. But for me, as the pulmonologist, normally a person gets referred for dyspnea and we're kind of starting from scratch. And ILD is always in the back of my mind as a possibility as the cause of dyspnea. But then we need to get more information. So we talked about this last time, but your history, you're thinking about things that point you in the direction of the cause of the dyspnea, as well as comorbidities that could make some things higher or lower on the differential. So when we're taking a person's history for dyspnea, of course, we wanted to talk about things that could point us towards heart failure or angina. Dyspnea as an anginal equivalent. We want to talk about potential asthma, COPD. So that would be different patterns to their symptoms and associated symptoms. And then exposures that put them at risk for lung disease, like smoking, like what kind of work they did, what kind of history they have. Did they have cancer in the past and get treated with radiation to their chest? Other exposures like that. And then a lot of times we really want to get into, if we are thinking ILD, we really want to get into whether they could have autoimmune disease, because a big chunk of ILD is associated with connective tissue disease. So do they have dry eyes, dry mouth, rashes, Raynaud's, joint pains, trouble swallowing, all those things. And then that will kind of tailor the workup. And then physical exam, similarly looking for signs of chronic lung disease, things that would point you in a certain direction, and comorbidities. A chest x-ray, I always get in someone if I don't already have one, because it will show like gross abnormalities if they are there. But if I have a suspicion for ILD, I'm not going to let a normal chest x-ray like this tell me that there's no ILD, because this is the chest x-ray may be not sensitive enough to pick up subtle findings. So I definitely will get a chest x-ray and then likely get a CT scan depending on, you know, if other things have convinced me. So I don't think a normal chest x-ray is enough to rule it out. Here is a pretty obvious ILD. Usually it's not this obvious, but you can see all little reticular markings, reticular meaning lacy. So it looks like there's just like lace draped over both lung fields. And then on PFTs, okay, so how do we know on PFT? This is a super brief PFT review. So if a patient has obstructive lung disease, that would be COPD, severe asthma, bronchiectasis. That's really the main three. Or like maybe a small airway disease like bronchiolitis. Obstructive lung disease, what are we looking for on a PFT? Wonderful. FEV1 over FVC less than 70. So that's found up in the spirometry part, FEV1 over FVC, and we're looking for the observed value, and that's 75. So in this patient, we would not be worried about obstruction. What about for restriction? And what other parameters would we be looking at on PFT? Okay, decreased total lung capacity, very good. So they are outlined in red. The total lung capacity is measured by lung volumes. The vital capacity and the expiratory volume are also lung volumes. They're just done with a different technique. So that's why sometimes we can sometimes we just have spirometry and we don't have the rest of it. And we might read that PFT or that spirometry as suggestive of restriction if these volumes are low. We can't really say for sure because the spirometry technique, if you've ever seen it, like the person has to take a deep breath in and blow out as hard as they can. It's not designed to measure lung volumes the way the lung volume testing is, but there are volumes involved in spirometry, so we can use those numbers to infer whether there might be restriction. But the total lung capacity is a better way to know if there is restriction. And then diffusion capacity may be low because if you think about diffusion of the oxygen, it has to go from the alveoli across the endothelium, the epithelium of the alveolus, then across some interstitium, then across the endothelium of the alveolar capillary into the blood. So if there's something there that's causing it to be more difficult for oxygen to get across, something in the alveolus or something in the interstitium, or in the case of pulmonary hypertension, maybe that vessel itself being thick, but that's going to reduce your diffusion capacity. So that usually speaks to ILD as well. So then if we, do the history of the physical and some preliminary testing, and we're thinking ILD, then we want to get a CAT scan, usually a high-res CT, but a lot of the time a regular CT is okay. But gold standard for evaluating ILD would be a high-res CT. So here are some examples of potential CAT scan findings. So maybe we can describe what we see. If anyone wants to pick one and describe a radiologic finding that they see, or I will start calling on people. Yes, Keith. By the way, Keith, thanks for the 2 patients.
Thank you. I think that looks like honeycombing.
Very good. So this part down here, right? All these little cysts on top of each other. They have you can see their walls. Their walls are bright white here, and they are starting at the periphery and then stacking inward. So I agree, that looks like honeycombing. Yes, Natasha.
It kind of looks like a mosaic.
Okay, bold move. What do you mean by mosaic pattern?
There's like patches that look a little bit more dense than others.
Okay, so what do you think is the abnormal part? Do you think the light part or the dark part is abnormal?
Likely the darker area.
It's like a very hard question to answer. So in this case, this is, I agree. So mosaic attenuation basically means that the CAT scan has some areas that are light and some areas that are dark, like a mosaic that has maybe tiles of different colors or whatever next to each other. It can be difficult to know which, when a patient has mosaic findings, if you don't know much else about what's going on, it can be difficult to know which is the normal and which is not normal. So if we're saying that the lighter gray is not normal, then we're saying this is what the lung should look like, and instead this is all ground glass. And maybe there's some septal thickening here. You can appreciate like a line there, a line there. So maybe there's fluid in between the lobules as well. If we're saying that so I think that's probably what's shown on here. If we were saying that this is normal lung and that this is not normal, then that would be air trapping, meaning that there's too much air in these areas that are dark, and that would be abnormal, maybe from bronchiolitis or something else. But for our basic purposes here, let's say that this CAT scan basically shows ground glass. So specifically, what is ground glass when it's read as just a, not like what does it represent or anything complicated, just when a radiologist says ground glass, radiologically, what are they trying to tell you they see? More basic, just like what is it, what are they saying about what it looks like on the CAT scan? What's different about this compared to like this?
Oh, it's like it's opacification
Okay,
as opposed to like a total whiteout, like a consolidation.
okay, yeah. So this ground glass means that you can see all the structures still, right? So like this is hazy, but we can see there's an airway here, there's blood vessels here. So we can appreciate all the structures of it compared to, what would we call this? C is for, yes, consolidation, where we can't really see here, there's an airway, okay, but like we don't know anything about this area here. We can't see blood vessels, we can't see other airways. We do have an air bronchogram here, but this area is what we call consolidated, meaning we don't see what's going on here otherwise, compared to ground glass, which is more of just like a haze, and that's why it's glass, right? You can still see through it. Okay, so we have ground glass with mosaic attenuation. We have consolidation, honeycombing. What else? What else? What else? What's happening here? Is this consolidation, ground glass, something else?
They're opacities, but I don't
Okay.
know why they look like that.
Do they look hazy? Do they look like ground glass?
They look hazy.
They look like ground glass. This is ground glass, but it's very central, right? It's like centralized around the hilum. So it's sort of an unusual appearance, but if you had a CAT scan, this might look like bat winging. So this is probably from fluid because the pulmonary veins are in the hilar area. So that's where maybe you would see congestion and pulmonary edema first. So that's ground glass as well, just a different pattern. This is more diffuse, maybe kind of patchy. This is more central. Here's another example of ground glass. These are ground glass nodules. You can appreciate like all throughout this lung, there are little discrete areas of ground glass. So it's also ground glass, but different from either of these patterns. And we talked about honeycombing. Here's some more honeycombing here. And what's this here? These airways here. What's not normal about them for anyone who was here the last time may remember?
They're ectatic airways.
Okay, so there's bronchiectasis. And is there bronchiectasis because there's a problem with the airway, like a person with cystic fibrosis gets bronchiectasis because their mucosa is not normal and their airway dilates?
Rob's not. It's more like it's from an ILD since there's reticular formation. So
Agreed. So traction bronchiectasis, we talked about how traction means pulling. Traction bronchiectasis means that these airways are pulled open because the rest of the lung is not normal. It's like scarring down, it's kind of shrinking down. So it's pulling, and it's pulling those airways open. So traction bronchiectasis and honeycombing are markers of fibrosis that we know are specific to certain types of ILD. So just to review, we talked about this a lot last time as kind of an important concept, especially when explaining this to patients. So ground glass on a CAT scan, as someone said earlier, basically represents inflammation. So there are cells that shouldn't be there that are causing this hazy appearance. And if this goes on for long enough, or if it's severe enough, it can eventually lead down the road to lung scarring or fibrosis. And then of course, once you get to this stage, the process is no longer reversible. This damage has been done. So the goal in all of ILD management is to identify why are the lungs inflamed and reverse it before they progress to becoming fibrotic. Sometimes they reverse on their own, like someone who gets a flu, and if it self-resolves, if you got a CT while they had the flu, they might have some inflammation. You get a CT a few months later, maybe it's gone. Someone gets bad COVID, they might get a lot of ground glass, their lungs are inflamed. You get a CT a few months later, they might have some fibrosis because maybe their injury was so bad or it went on for so long. So that's kind of the main point of figuring out ILD and monitoring the course and reversing the inflammation before it turns into fibrosis. That's our goal here. So we know that this is the general scheme, is that something injures the lungs, and then all of these things happen with like cytokines and and then the end product, if this is not reversed, this cascade will be matrix deposition, aka fibrosis. So we want to target this inflammatory response to reverse it or figure out what the cause is here, which we're about to talk about more. So we just talked about this progression to this, but to remind you about IPF. So we talked about IPF more extensively last time, so we're not going to go into tons of detail. But for those of you who weren't here, IPF is idiopathic pulmonary fibrosis. It violates that rule that I was just talking about. I was just saying that lungs go from inflammation to fibrosis, right? That some insult causes inflammation, and if we don't reverse it, then the lungs become fibrotic. In IPF, the F for fibrosis, this is just a fibrotic disease. There's no inflammatory stage of it. For some reason that we don't really understand, the lungs just start to scar. That matrix deposition just starts to happen without it going through an inflammatory period first. So the findings, there's not ground glass, there's reticular fibrosis, so these little kind of lacy white markings, there's honeycombing, there's traction bronchiectasis, there's not ground glass, and usually it starts in the periphery. If it gets severe, it can take the whole lung, and usually it's in the lower lobes. It's mostly in older people. It's really unheard of under age 50, and usually people with a smoking history, but it's not known like how smoking contributes to it. And there are antifibrotic medications rather than the anti-inflammatory medicines that we usually use. So we don't put people on chronic steroids and things like methotrexate and Cellcept. Those would be for other types of ILD, but not for IPF. So that's important to remember because it's managed differently. It's like seems to be asked about a lot on boards. Okay, so last time we went into IPF and we touched on some of these other inflammatory lung diseases that are kind of called unknown causes, meaning, people just get these idiopathic findings on their CAT scan and we can't relate it to anything in particular, but it has a certain pattern appearance on the CAT scan or a certain pattern on biopsy, and that's how it gets one of these names. We're going to move on to ILD associated with known causes, so known comorbidities or other exposures. So connective tissue disease related ILD, it can be involved in a patient who has any of these: dermatomyositis, polymyositis, RA, lupus, scleroderma, Sjogren's, mixed connective tissue disease, and small vessel vasculitis. All of these connective tissue diseases can have an ILD that precedes their diagnosis. So the person may not come to you and say, like, I have lupus and I have trouble breathing. They might be like, I have trouble breathing and I get like this rash sometimes. And then you will, the process begins, or it may precede it by a long time. And the only thing that they have is lung involvement. And then years down the road, they may develop a connective tissue disease that's diagnosable by serologies. So you have to keep a pretty high index of suspicion because a person could always have a connective tissue disease that hasn't been diagnosed yet as the cause of their ILD. But basically, like a sort of a very basic concept, you can think that those autoantibodies that are attacking the joints or the skin or whatever are also attacking the lungs. And CHEST has a pretty good set of guidelines about what you should ask the person, which is kind of what we just talked about earlier about the symptoms that they could be having, and then physical exam. So this is mechanics hands. The hands get really dry and cracked, and then the cracks get kind of dirty, so they look like a manual labor or mechanics hands. this isn't showing up that well, but these are Gauthrin's papules. They're on the extensor surfaces of the fingers. They're kind of purpley violaceous nodules and plaques on the hand. And then sclerodactyly is tight skin along on the hands that can lead to deformation of the fingers. And then all these labs are usually what we send when someone presents with ILD if we don't know the cause, because again, we don't know, they could have an autoimmune disease that just hasn't been diagnosed before. So we send like a whole host of things. And then usually, as it says here, patients should get a high-res CT, and NSIP is the pattern most often seen. So NSIP is just a type of inflammatory pattern. It means ground glass that's along the periphery that has a little bit of sparing here at the very periphery. Don't worry about that. This is just like to show you though, if you hear this term NSIP, it's just a radiographic pattern, or if there were a biopsy, it would describe how the biopsy looks. Similar, organizing pneumonia is another type of, basically like a description of the ground glass, how it's located. Organizing pneumonia is usually more patches compared to the NSIP, which is more confluent. So organizing pneumonia can have a lot of different causes, but it's describing is the radiographic appearance or a pathologic appearance on biopsy. So these are some patterns of inflammation that could be seen in a patient who has a connective tissue disease, ILD, this one being the most common. Drug-induced ILD, there are so many drugs that have been associated with ILD. Mostly I would recommend asking about prior cancer and prior cancer treatments. If they've gotten radiation, like, you know, exactly where was the thing that they got radiated for, because a lot of times, like, you know, the beam just hits the lung and causes some inflammation or fibrosis there. You know, amiodarone is kind of common. It's probably overblown how much it actually causes ILD, but it is something to ask about. And then the immunotherapies, which are used for lung cancer and melanoma and renal cell and some other things like nivolumab, pembrolizumab, those can cause pneumonitis. And it's important to recognize those, because if the pneumonitis is bad, then you have to stop these drugs and find a new plan to treat the cancer. So that's all I'm going to say about drug-induced ILD. Occupational exposures or pneumoconiosis. So I always say to patients who I see in clinic, what kind of work have you done in your life? A lot of jobs can affect the lungs, because you say, what kind of work have you done? Sometimes you get like weird answers. Keep them focused. So a lot of things, I feel like I said, I think I said this before about how boring the like occupational histories were in the Northeast compared to down here, where like everyone's worked in a mine and a carpet mill and a foundry. So here are just some pictures. I have a patient who works at Lodge, and she says like when she blows her nose, it's just like black soot. I have a lot of patients who work in foundries, which I didn't really know what that was until people started talking about it. And a foundry, if you don't know, is where like hot metal is poured into moldings to make like metal things. A lot of patients have worked in construction in some form and have been exposed to asbestos. And then people who have worked on ships often have been exposed to asbestos because it was used to line ships like for insulation. So a lot of people have done like stripping for the Navy, have been exposed to asbestos. There are fabric mills, sock mills, and carpet mills. This is a silica quarry. So silica is basically sand. And so it has all different uses, but it's definitely a culprit for ILD. The particles are very small, can cause acute or chronic lung disease. And silica is used in making sandblasted jeans by like blasting the jeans with silica at high speed. And it is done like in other countries where most of our clothes are made without a lot of protective equipment. So sandblasted jeans are a big culprit for ILD. And of course, mining. And then hypersensitivity pneumonitis is different from a pneumoconiosis. In a pneumoconiosis, it's the fiber or the metal dust or the sand itself getting into the lungs and causing problems. In hypersensitivity pneumonitis, it's an immune reaction to something in the getting into the lungs. So a little bit different because the immune reaction is more easy to control, right? If somebody works like does sandblasting and they get sand in their lungs, you can't really help that. You can't like go in and take out silica. But if someone has hypersensitivity pneumonitis, you could potentially treat that or moderate that immune response. So chickens are a huge culprit. Chickens and anything with feathers like down pillows or feather beds carry little fungal elements on them that some people, when they inhale them, cause a big response in the lungs. Similarly, hot tubs like thermophile bacteria can live in here and then become aerosolized. Plastics, cattle, timber, and other things in logging, when trees are cut, they release spores. So all different industries or hobbies can result in hypersensitivity pneumonitis. Usually the person can give the history that their breathing is worse when they're like at their job or doing their activity or whatever. And then when they're home or like removed from that exposure, they get better after a few days, but then it will recur when they're re-exposed. So a history like that is pretty classic for hypersensitivity pneumonitis. You try to get them to avoid the exposure, but it can be treated with steroids or other immunosuppression if like it's gotten to the point where their lungs are really inflamed. So here's a question. I am going to let you read it to yourselves, and then we will talk about it. Okay, so can anyone summarize this concisely with the important, pertinent pieces of clinical information? What is this clinical syndrome? I'll walk you through it. Okay. Healthy or unhealthy person host? Healthy. Acute or chronic problem? Acute. What's like the main feature of the problem? Dyspnea, cough. So healthy person with acute respiratory symptoms. Anything else pertinent in the history?
Harvesting wheat.
Okay, with wheat exposure, and then with an abnormal chest X-ray, right? And that pattern of the symptoms beginning at the beginning of the work week, and then so it's very associated with his work. So I call this a young man with respiratory and systemic symptoms associated with workplace exposures with upper lobe nodules on imaging. Most things that we inhale go to our upper lobes. So emphysema usually starts in the upper lobes because smoke rises. So if you think of things that like respiratory antigens and respiratory insults often rise. So think about that. Upper lobe nodules maybe gives you a hint also that this is an inhalational problem. So what do we think is going on? What would his presumed diagnosis be? Very good, hypersensitivity pneumonitis. So what should we do for him? Tell him to quit that stupid job. Yeah. Because we don't think we need steroids. He's still breathing room air. You know, he hasn't tried really abstaining from work. So that would be the answer there.
So
yes.
what if the question included a part of saying he needs more of his job?
Interesting. I guess if the person's going to have continued exposure, then you would treat them with some kind of immunosuppression, starting with steroids. And if they respond to steroids, usually for ILD, you start with steroids. If they respond to steroids, like their symptoms or their imaging get better, then that means, you know, they will respond to immunosuppression. So you then try to bridge them to something else to get them off steroids, usually cellceptor azathioprine.
Can he wear a mask?
Yeah, he could wear a mask. Usually for most particles, like the things that we were talking about causing pneumoconiosis or hypersensitivity pneumonitis, they would need to wear a respirator rather than just a simple mask, because most of the times a mask wouldn't be adequate. Okay, smoking related ILD. So there are a lot of ILDs that are sort of related to smoking. Like we talked about how IPF is more common in smokers, but we don't really know why. There's another one, pulmonary Langerhans cell histiocytosis, more common in smokers. But this is an ILD. These are two ILDs that are probably on a spectrum that we think are directly from the smoking, because if the person quits smoking, they can usually get better. So RB-ILD, respiratory bronchiolitis ILD, is upper lobe predominant little nodules. So there's an example of one. There's one. There's one. A lot of times our smokers get a low-dose CT for lung cancer screening, and they have like little nodules, and they're like, well, what is it? Like, what is, is this cancer? If it's not cancer, what is it? And a lot of times it might just be, this kind of chronic inflammation causing nodules to come up, but it's called respiratory bronchiolitis, ILD. Then if this kind of progresses, maybe it's on a spectrum, not sure, whoops. There's another one called desquamative interstitial pneumonia, DIP, like tobacco. You can maybe put that in your brain. And that can cause ground glass changes and nodules. So this one's a little bit more of a classic ILD, like with ground glass changes, whereas RB-ILD is just upper lobe usually, but mostly nodules. And I put these here to remember because when I was growing up, my mother smoked Marlboros. And so when I was in fellowship trying to remember this, I thought of the RB as standing for red box, because that was the Marlboros. So this is associated with smoking. My mother quit smoking. Thank you. Okay, here's another question to read to yourself. Okay, someone take a stab at a clinical syndrome here.
Six-year-old asymptomatic woman with 35-pack-year history of smoking, low-dose CT showing nodules.
Okay. Agreed. Smoker, asymptomatic, upper lobe, predominant nodules. So what do you think she has?
D.
Great. Respiratory bronchiolitis associated ILD, RB-ILD. Okay, excellent. Okay, so we talked about, let's go on. Yeah, we talked about those. Let's go on to sarcoidosis. So sarcoidosis, we don't really know the cause. We don't know why people get granulomas, but we know that the physiology, the pathophysiology of sarcoidosis is granulomas where they shouldn't be. Really, they shouldn't ever be. So just granulomas. So granulomas are basically this abnormal collection of cells, multinucleated giant cell, macrophages surrounded by lymphocytes. So it's like a specific type of inflammation that's organized into these non-necrotizing granulomas. So sarcoidosis can be pulmonary, it can be extrapulmonary, often it's both. So it can affect all these different organs. You can get neurosarcoid, lymph nodes enlarged, spleen, liver, rashes, eyes, skin, heart, joints. So it can really affect a lot of the body. Pulmonary sarcoid can show up in two different ways. Here we have hilar adenopathy. So the lymph nodes in the chest are enlarged. And you can also get an ILD that's more diffuse involving the parenchyma. So small nodules, inflammatory changes like ground glass, or it can progress to fibrosis. So there can be the hilar adenopathy, representation of pulmonary sarcoid, or the parenchymal. So this is a pretty classic description that was published years ago about how people present with sarcoid, what their x-ray looks like when they present. So some percent have sarcoid elsewhere in their body, but no involvement of the lungs. Most of the people have just lymphadenopathy. So like depicted here, just enlarged lymph nodes in the chest. And some people have enlarged lymph nodes and some findings in the parenchyma. Some people don't have enlarged lymph nodes and just have findings in the parenchyma. And some have findings of fibrosis. So there's kind of a spectrum of findings, and it can be difficult if a person is just presenting like with just pulmonary parenchymal findings that just ground glass or something. It doesn't really look like anything too specifics, but it should always be on the differential that sarcoid could be a cause of an ILD that doesn't have a known cause. So the diagnosis is made by a compatible clinical presentation, like a chronic indolent process, maybe non-necrotizing granulomas found in tissue. So a biopsy of the lymph nodes in the chest, a biopsy of some other lymph nodes somewhere, or a piece of the pancreas that we thought was cancer is actually sarcoid, liver that looks cirrhotic, it's got sarcoid. So different tissues can be biopsied and give that answer, and then exclusion of other causes of granulomatous disease. So make sure the person doesn't have histo or something like that that could be the cause of the granulomas. Most people have spontaneous regression. So they have lymph nodes that are enlarged in their chest. They don't have symptoms. A couple years later, that has gone away. In some patients, it stays and there's some scarring, so they get calcified lymph nodes, but it doesn't progress. Nothing more happens with it. About a quarter require treatment, and then about 10%, I didn't realize it was that high, about 10% proceed to respiratory failure. And the treatment is usually steroids, and then there are other immunosuppressants that can be used. So we talked about, that was pulmonary sarcoid. Then there's extrapulmonary sarcoid. So the Blue Journal of the ATS has this long list of recently published guidelines of what you should do if you have a patient with sarcoid. What else do you need to test them for? Because we just said that sarcoid can affect all different parts of their body. So you want to make sure that they've been assessed for whether they could have extrapulmonary sarcoid. So to summarize these guidelines, basically it says, if they haven't had it already, when they're diagnosed with sarcoid, they should have a CBC, creatinine, LFTs, calcium, an EKG, and an eye exam. If all that is normal, then there's a criteria about what you should monitor every year. Basically, you need to monitor calcium, creatinine, and alk phos every year to look for signs of whether the sarcoidosis is causing, affecting other organs. Then an eye exam or cardiac testing could be considered if there's a change in symptoms. Okay, so here's another question. I think it's just an image. So just look at the image and think about it. Anything notable on this chest x-ray? Excellent, Tanner. Great observation. So this is a healthy young woman with oh no, it's not just an image. Okay, healthy young woman, incidentally found asymptomatic bilateral hyaluronopathy, right? So what is the most appropriate management? Observe, right? Because we just said that a lot of people regress spontaneously, don't ever have symptoms, don't ever need treatment. So unless there are some red flags, like the important thing in this patient was that she was asymptomatic. Of course, if she's having like fevers or other problems, you're not just going to ignore that. But if she's asymptomatic and there's just hyaluronopathy without anything else, it could be reasonable to just observe. Okay, the last two I'm going to touch on real quick, just 2 slides of weird other ILDs that I have seen on mix-up questions. So I'm going to tell you about PLCH, pulmonary Langerhans cell histiocytosis. This is a weird name and it's weird looking. So like irregular cysts, cysts mixed with nodules, mixed with ground glass, weird looking, usually in a young smoker, and it can improve with smoking cessation. And then the lamb, lymphangioliomyomatosis, is usually in a young woman, and it's these thin-walled cysts, a lot of cysts throughout the lungs. And it's probably related to estrogen, which is why it mostly really only occurs in women. So I'm going to have just like 2 more questions to pull it all together. Okay, so which of the following diagnoses is suggested by these chest radiographs? I think I didn't provide the lateral. I apologize. Which one? Okay. Yeah, I couldn't get those circles to carry over. Okay, sarcoid, because what do you see? Okay, very good. Why not IPF? What would that look like? Okay. And yeah, so diffuse parenchymal infiltrates, you would definitely see like lacy or honeycombing traction bronchitis. So just there should be more in the parenchyma. Lamb, we just talked about. What would that look like? Cysts, emphysema. Lymphangitic spread of tumor usually looks like heart failure because the pulmonary vein and venules and the lymph vessels travel together. So you would see maybe like curly B lines and stuff like that, because this implies that the lymphatics are like engorged with tumor cells. And then silicosis usually is upper lobe, because we talked about like it's an inhalational problem. Okay, excellent, sarcoid. And then here's the last one. Okay, who can make a clinical syndrome for us? Natasha.
So this is a 72 elderly gentleman who has symptomatic cough and dyspnea. And
Acute or chronic?
it sounds like chronic.
Mm-hmm.
History of back disease. And he also has evidence of honeycombing.
And what do those make you think?
IPF.
Yeah, those are fibrotic changes. Okay, very good. So yeah, an older man who's a former smoker with chronic dyspnea and CT showing fibrotic changes. So once you put it that way, it's like, obviously that's IPF, right? So that's IPF. So DIP we talked about as that smoking related ILD. Hypersensitivity pneumonitis we talked about as being an immune response to inhalational something, mostly upper lobes. IPF and PLCH we talked about, mostly young men, crazy looking infiltrates, and then RBILD we already talked about. So we don't need to summarize because we already know what we just learned, and thank you. Questions? Okay, thanks.